But to start off, the topic of the conversation today is infection prevention and control practices in clinical office settings during the COVID-19 pandemic. So we'll get into the objectives of the presentation in a minute, but just a few housekeeping things. Firstly, who am I? Tim Cronsberry. I work with Public Health Ontario, and I'm the manager of the Infection Prevention and Control team. And with us today, we have two presenters, Dr. Jaya Nataraja, and Jaya is an infection prevention and control physician with Public Health Ontario, as well as a practitioner at Markham Stouffville Hospital. Hopefully she won't get interrupted by a code during this presentation. And we also have Rohit Garg. So Rohit is an IPAC specialist at Public Health Ontario and is serving as our lead for primary care support. A couple of other housekeeping things today. You'll see, and as usual in Zoom, there is both a chat pod and a Q&A pod. So if you have particular questions, you can enter those into the Q&A pod at any time during the presentation that you like. Your question may be answered within the material that we already have in the presentation. If not, we'll try and answer most of the questions at the end. There should be plenty of time at the end to answer most of your questions. We may answer them on the fly, though, during the presentation if it's particularly pertinent to the material that we're covering and the information on the slide doesn't completely capture it. So we'll try and do a bit of a hybrid model with answering questions, but most of them will be at the end. But at any time during the presentation, you can enter those. As for the chat pod, if you have particular thoughts or anything like that isn't strictly a question, then you can use the chat pod as well. And that will be visible to all of the participants, whereas the Q&A pod will just be visible by us in the background. So I'll stop there and turn things over to Dr. Jaya Nataraja to start our presentation. Jaya.
Perfect. Thank you so much, Tim. And thank you so much for having us here today to talk to you about how you can develop a model of safe in-person care in your office practice. So we'll just go through some of the objectives today. So we hope by the end of this webinar and through using the resources that we will highlight throughout, that participants will further understand how to apply an IPAC risk assessment to prevent transmission of infection in your clinical office settings. No matter how small or how big your practices are, all of these principles will apply. Understand what are routine practices and what are all of these additional IPAC measures that we have applied during the pandemic. And we will also sort of do some practical review of the current recommendations for selection and use of PPE. And we've tried to put in scenarios that are more applicable to what you would come across in a typical office practice. And we also want to just overall, at the end of the day, have you feel more confident in your practices to further develop a future model of care, which I think we're all moving towards for in-person assessments that's balanced with some virtual care as well. So just a little background on what is the role of Public Health Ontario, and the role of Public Health Ontario and how we fit into our sort of other provincial agencies. So our mandate is to provide scientific and technical advice and support those who work in government, public health, healthcare, and other related sectors. We have lots of stakeholders, and our role is to build capacity, but we're still considered arm's length to the government. So we publish best practices, but you may come across other guidance published by the ministry, the government, or other agencies applicable to your sector. And sometimes, and I'm sure you're not surprised over the last little while, is you probably have seen recommendations that may be a little bit different from what is considered best practice as well. And so as we walk through the webinar, you'll see what we publish on is best practice, but also a little bit of feasibility and implementation when it comes to recommendations. So let's start with something that we often get asked about, which is what is a risk assessment? And essentially, there are two types of risk assessment that you would perform as in your organization. One is an organizational risk assessment, or ORA. And this is a systemic approach to assessing the efficacy of all the control measures that are in place in your organization to mitigate the transmission of infection. And whether it's a hospital or a private clinical office, the risk assessment goes through the same layers of what we call control measures. And in this talk, we will give you a virtual walkthrough of your office and, in a sense, go through some of these steps. But at the end of our presentation, we have several slides and an appendix that will walk you through an ORA in a lot more detail that you can refer to at any time you want. A point of care risk assessment or a personal risk assessment is at the individual level, and it's to be used by every single member of your staff before every interaction with a patient or that patient environment. A lot of us do this very quickly in the back of our minds, but it does take training and education to get good at it and have it like that secondary sixth sense. And a personal risk assessment involves looking at the patient environment, the status of the patient, and then finally the task at hand. And we will walk you through some of that in this presentation as well. So the first thing during this pandemic, as we progress through waves and lulls, one of the aspects of your organizational risk assessment is looking at some of these indicators of COVID-19. And essentially, you're trying to perform this population level risk assessment, but what does it mean for your office and your staff? What's going on in this community? And this is just some websites that are in our PHO landing page that provides a lot of these metrics and epidemiology, not just of COVID, but other circulating viruses as well. And especially for next flu season, it'll probably become a little bit more important. There's lots of other IPAC tools here as well to peruse on our landing page. So let's look at what's meant by a population risk assessment. I'm just trying to get rid of this, but it's not going anywhere. All right. So what does it mean? So how do you translate what's happening in the community into what the risk is in your office or in your setting? And, as community incidence goes up, we can expect more likely encounters with patients who are incubating COVID or pre-symptomatic or asymptomatic or just even floridly symptomatic with COVID. But when we look at transmission of illness in a healthcare setting, the vast majority of transmission to staff and other patients in your setting is from unrecognized illness, either in other patients or staff. When someone's symptomatic, we know, we apply the appropriate precautions, we're very careful, we do everything. But what we want to do is prepare your office for the possibility that there's an asymptomatic, unrecognized person walking around. And if you speak to anyone in IPAC, we assume everyone is infectious at all times. So all of the measures we put into place is to assume that, therefore, you always have this invisible barrier of protection for the unrecognized illness. And these are a list of some of the metrics in the community that you can look at to really give you a sense of how much of this illness could potentially be in my office at any one time. So there's, metrics of positivity rates. I'll go through some of this, but in very quick overview, wastewater surveillance, we talk a lot about it. We talk about hospitalizations and ICU admissions, and it's important to look at this because the more hospitalizations and ICU admissions there are in terms of severity indicators, the more stress there is on the healthcare system as a whole, which will affect your office. Look at the vaccination rates within your office staff and your patient population, because it will have a significant effect on the risk within your office of transmission and of severe disease, either in your staff or your patients. And really, at the end of the day, you can follow these metrics either at a provincial level, a regional level, or a local level at your public health unit, which probably is the most applicable to what you can look at for the risk in your office. And these are just quick charts that I'll go through. This is from the Ontario Science Table. It's the wastewater signal, which basically looks at gene copies of SARS-CoV-2 across about 100 wastewater treatment plants and pumping stations and sewer sheds it is representative of all the 34 public health units in the province, but there is a significant regional variation. So there are regional specific data that you can look up in your health units as well. And really, we look at this as a signal. It's to be interpreted amongst all of the other metrics that we talked about, but it is something to just keep an eye on in your area to see where things are at in terms of how much SARS-CoV-2 is circulating in our wastewater. So this graph is from our PHO website. It's percentage of confirmed cases that's sort of broken down by age group, which is important for us because it really gives you a sense of what's happening in different age groups. So looking at the strict numbers doesn't really help us as clinicians or as people trying to determine risk in our setting, but looking at trends in age groups, right? So if you're a pediatric practice, look at the trends in the pediatric population. It's also helpful to look at the trends in healthcare workers, because then you start to see correlation with vaccination and waning immunity. And maybe it's time to sort of call up your patients and say, hey, we really encourage you to go and get that third dose or that fourth dose. This graph just shows you the different variants. And this is also graphs that can be obtained at the PHO website. And the Ontario Genomics Network looks at sequencing most of our COVID-19 specimens. And you'll see that as different variants come and go, other different variants will start to dominate, and they could be more severe, they could be more transmissible. So this is just for out of interest. If you're wondering what's happening with BA2 and BA1, you'll notice that BA2 is now the most prevalent lineage, which makes up over 50% of what we're seeing in Ontario, probably over 90% at this point. One of the important things to look at is the hospitalized confirmed cases in Ontario. And this is broken down by people who their vaccination status as well. So we know there's evidence that vaccines provide protection against severe disease, and this protection is even more important in the higher age groups. And it's important to look at the surveillance tool because you'll start to get a sense of who's getting hospitalized, how does that correlate with vaccination, and are we seeing a waning immunity in our population? Because as we start seeing that, you'll probably start seeing more of them coming into your office, and it may be time to start adjusting or refreshing your IPAC education. Okay, and this is another way that we look at our data that breaks it down into different settings. The important part of this slide is that really we're not seeing major outbreaks that are correlated with medical or dental clinics. And, dental clinics perform some of the highest risk procedures right in the center of a site of infection with high levels of spray and splash and aerosol generation. And we really have not seen significant levels of transmission, which is very reassuring when it comes to looking at the effect of the control measures that dental clinics and medical clinics have had to date. Okay, so let's move on to walking through your office now that we've sort of looked at how the population risk assessments work. Okay, let's start from the outside in. So one of the important things to do when you get back to your office today is to sort of sit back and say, does the layout of my office facilitate infection prevention? And the three main areas to look at are your waiting area, which I think for all of us is the bane of our existence. Our clinic has a very small waiting area that can barely accommodate 3 distance patients. So we really have to look at what we can do to increase the capacity of our waiting area. Do you have a dedicated exam room or a space that is ideal for someone who may need to be isolated based on symptoms or a positive screen when they come to your office? And do you try to at least separate administrative and clinical areas? Because this will decrease exposures. You can maybe give a little bit of clutter in your admin area and then keep the clutter away from your clinical area so it's easier to clean. Think of how you can make your clinical area as separate from the admin area as possible. And other things to really look at is also, do you have the appropriate signage? Are they placed in the right areas? Are they legible? Are they able to be interpreted by patients? Should they be in other languages? And one of the most important things in IPAC is to declutter. And you'll see that throughout the presentation as to the importance of why we should declutter the office. So screening. Screening is performed in general to identify symptoms and exposures. And there's 2 different kinds of screening. passive or active. And don't forget, we're screening about not just COVID, but other infections too, like gastrointestinal infections that could come into your office and spread very quickly. And what screening does is really help you identify strategies that can decrease the risk of transmission to others, right? So if you identify someone who's screen positive, you can do something about it early than later when they're finally in your clinic room and then they tell you what their symptoms are. It also gives you the opportunity to help them wash their hands and to help them put a mask on properly and take them right to the room if you need to. And the screening questions are updated quite often based on epidemiology of communicable diseases and more knowledge as we attain more knowledge on symptoms. And screening can also change based on the immunity in the local population. So if you get a new variant that is a complete immune escape, we may need to go back and do different screening questions for that. Okay. And so these as passive screening is done by having a signage at the entrance, and you expect staff, patients, and visitors to identify themselves if they're ill. Active screening, which is what's still currently recommended for all patients, is to ask them a question and have them attest to answers. And active screening kind of lets you preemptively find any risks before they come to the appointment. So if you screen them prior to them coming into the office and screen them when they walk in. And what we really want to progress to is we want active screening or passive screening, not as a tool to eliminate patients from coming into an office, but to really preemptively inform you that there may be a risk coming to your office. So let's deploy the appropriate control measures. Whether it is that you reschedule them because it's a non-urgent appointment, or you see them because it is an appointment that needs to be seen, but put them in the appropriate precautions and have the appropriate protocols in place. So I think one of the main things for active screening is that it is really meant to try to normalize it and make it okay and support your staff and patients in being comfortable in attesting to symptoms or exposures without feeling like their care will be compromised. And that's sort of where we want to get to. So moving on to distancing, and we have more details on this in the appendix if you want a little bit more tips on distancing. But essentially, distancing is probably the most difficult thing that we can do in our office. And I have a very difficult time in my clinic to be able to distance all of our patients throughout their appointments. Most of them show up 15 minutes early, so they're all sort of in the waiting room at the same time. And so what you've probably all done is institute a model of staggering your appointments between virtual and inpatients, which works very well. Really attempt to schedule patients with communicable diseases at the end of the day. This causes less disruption. It causes less exposures as well. In break rooms in particular, make sure you check it here and now and again to limit the number of chairs to facilitate the distancing in the break rooms. And one of the most important, particularly in the office setting, is to balance occupancy with access to care. And we hear this all the time. You want us to distance, but we need to see all of these patients. How do you expect us to do this? And being able to facilitate higher occupancy is becoming more and more necessary so you can actually see your patients. Some patients need more than one support person, and you need to start seeing our huge backlog of patients. And sometimes it's just you need to see multiple members of your family at the same time. I found it very difficult to book appointments for all my kids at the same time, even for simple things like their vaccinations. And so though distancing is a very effective measure, if you really need that higher occupancy, start looking at other control measures that you can optimize so you can actually give a little bit more leeway for having more people in your waiting rooms or seeing more patients in your office or booking a family all at the same time. So things you can do is to ensure well-fitted masks, ensure that you optimize ventilation, air quality. We'll talk about that in a little bit. Open your windows, things like that. We'll cover more tips on that. And start looking at maybe even differential appointments. So if you have a bunch of vaccinated patients, if they happen to be a little bit less distance in your waiting room, the risk is lower than having several unvaccinated and unboosted patients in your living rooms, in your waiting room. So you can start kind of playing around a little bit to decrease the risk, but really try to balance access to care. Another thing that we talk about quite often are barriers, or the physical barriers. And more is not better. So we have to be very careful when you start putting barriers in place. The highest yield for the use of a barrier is probably for that screener who's that first point of entry, talking to a patient who still has an unknown screen. But barriers are a double-edged sword. And they protect from larger droplets, but not necessarily against aerosols unless they're sealed airtight. And secondly, if you have too many barriers in a room, you can very significantly affect the airflow and air circulation. And don't forget, they also need to be cleaned. So be a little bit more choosy about using barriers and where to place barriers and where you actually get the benefit of your barriers. So moving on to universal masking. As we know, we all wear masks to protect others from us as source control to keep our secretions to ourselves. And well-fitted medical masks can be worn as source control. N95s or KN95s have a very good fit. They have not been shown to be any more effective at source control in terms of transmission of infection. So you don't feel compelled to wear a respirator for source control at all. And this is usually, you're going to start seeing masks being lifted in terms of public health measures. And we still have masking in all healthcare settings at this time. And you might even start seeing masking recommendations differing in different settings or different regions or different health units. And the province may not make a provincial mandate at all at this point or in the future. So just make sure that you're following the jurisdictional guidance for your healthcare setting. But if you locally feel like the risk in your office for all those reasons we discussed based on metrics is very high compared to what the provincial guidance may be, then you can very well make your own decision in your own facility to actually continue universal masking. One of the things to make sure you remember is that if you put a mask on for universal masking, you can keep it on all day if you want until it's contaminated or wet or hard to breathe through, or you've taken it off because you're eating, let's say. Make sure you wash your hands before putting the mask on and after taking it off. If you now go into a room and you're using your mask as PPE, then it's considered contaminated. So then you need to remove it as well. And we've got lots of tips on how to use universal masking in healthcare on our 2-page only tip sheet that we have here, okay? Okay, so this is probably the hottest topic right now in the pandemic, which is indoor air quality and how do we improve indoor air quality. And we know air quality is important for a number of reasons other than infection prevention. Now, in terms of infection prevention, the risk of transmission, even for COVID-19 or other respiratory infections, increases through close contact, crowded settings, and particularly if they're inadequately ventilated as well. So all three of these things put a higher risk for transmission. What is ventilation? Like, ventilation is a very specific definition. So it's removing stale indoor air and supplying fresh outdoor air into a given space. And that outdoor piece is very important. Ventilation is only of benefit in addition to other layers of measures. We have no evidence to date that shows ventilation on its own has had any significant effect on infection prevention. It's important, but it needs to be used with your other layers of protection as well. Okay, and don't forget, the more stuff, the more clutter you have in your room. You could have the greatest HVAC system in the world, but once that room is cluttered, there is airflow and no air circulation. So you're really not supplying that fresh outdoor air into your room. All right, so let's look at what can you do today when you get back to your office to do a quick air quality check, to do what you can to optimize whatever is in your office right now without putting in $1 million HVAC systems, to make it essentially as good as it can get where ventilation can prevent transmission. HVAC, make sure it's inspected, make sure it's maintained, and is it up to code if it's applicable? If you work in a big office center or clinical practices within another healthcare facility, there may be codes that you have to actually abide by. Look at all of your intake vents and your supply vents. Are they clean? Is air blowing and returning? You can hold a little piece of tissue paper to check this. All you need to do. Make sure there's at least 6 inches of clearance around all of your vents because you need that circulation. What is the circulation like in your office? Does it feel stuffy? Do you find lingering orders there for hours after somebody's heated up their food in the microwave, or other orders in the office? Do you feel drafts? Do your doors shut and seal properly, or is there always some issue with the seal? One of the things you can do today to improve your air circulation that works actually very well is to run all of your exhaust fans in bathrooms or kitchenettes throughout the day. If it's too loud, run it off and on throughout the day. And it really helps with your air circulation and getting some of the air exchanges and just getting air circulating around a room and not remaining stale, which is important. Look at crowding. Is there always more people in a room than what the capacity is? Do you really need all that furniture and drapery and physical barriers and storage boxes and multiple desks within your room? Right? Decluttering is a big barrier to clutter is a big barrier to IPAC. Windows are really helpful. Look at all of your windows. You can open them to help draw in fresh air, and you can actually exhaust indoor air outside to increase air exchanges by pointing a fan directly out a window, away from people's breathing zones and away from things that can blow like dust or sand, but that can really help you. Even if you just do it during lunch and a couple of times a day, open your windows up as much as you can. Even if it's winter, open it up first thing in the morning, open it up kind of at lunch, and you can increase that air quality very well. All right. So let's go on to look at air cleaning or air filtering. And we get a lot of questions about the portable air filters and the HEPA filters and what's the role of this in all sorts of settings. And so the difference between ventilation and filtration is actually fairly a big difference. A filtration is when you use different types of fibrous media that you suck the air through and remove particles from. And a HEPA filter is a classic example of what we use in healthcare. But air filtration is actually still less preferable to ventilation, where you're replacing that air with fresh outdoor air versus just filtering it through something. And there are, I've put in a few details about these portable air cleaners and air purifiers because we do get quite a few questions about it. The reference that we have listed on the slide has lots of good information if you have time to go and read it. But essentially, for portable air cleaners, there's a lot out there, right? One of the key safety issues is you need to avoid units that produce the toxic ozone, and that it can be toxic to people's lungs. You got to make sure that it doesn't produce that. Check your clean air delivery rate, or the CADR, which is a combination of the filter maintenance, and the rate of airflow. And that number is on all the boxes if you buy commercially, and it will tell you how big the room is that this unit is good for. It's kind of similar to humidifiers, but it actually gives you in square footage or square meters what the maximum size of the room is that this can filter. If you have a bigger room than that, you might need either 2 machines or you need a machine with a higher CADR. Just don't forget though, for it to actually accomplish that entire room filtration, you need to put it at the highest setting. And some at the highest setting are really loud. And then that actually impacts your office because you can't hear anything patients are saying to you. Make sure you place it in a central location, not in people's breathing zones, not blowing from one person to another, which can be difficult. It's like in a waiting room, it's not really feasible in most areas. If you can't put it in the center, at least put it somewhere where it's unobstructed in terms of its airflow and there's still a bit of room around it. And it's very important that you clean and maintain it as per manufacturer, otherwise it won't work the way it's supposed to.
Jaya, if I can
Yes.
just jump in for a second, because there've been a couple of questions that have come in both through the Q&A and a couple of comments in the chat, and it's really pertinent to what we're talking about right now, and actually links in with the slide that you just advanced to as well. So you've talked about air circulation, and you've talked about barriers like plexiglass and clutter and how that impacts air circulation. So the couple of specific questions are around when either in the reception area or other areas where you have staff members that aren't able to distance with their workstations, and the use of barriers like plexiglass. And I know it's not always a clear-cut answer, but I wonder if you can just comment on on that, and that risk assessment piece about saying, if you can't distance, are plexiglass barriers okay, given the trade-off with air circulation?
So that's a good question. So if you can't, so you're always masked, which is really important. If you need to put more staff in your office, the couple of things you can ensure is that they're always masked. They're wearing very well fitted masks, and they're not in each other's breathing zone. So even if you're just placing them behind each other, so one person's facing forward, the one person's facing the other way, kind of like our clinic office here is set up, that also helps as much. And then plexiglass, perhaps what you can do is, if there are staff, one plexiglass or two, it's hard to say how it interferes with your air circulation. There are ways to check when it comes to that by doing smoke tests and looking at the way air vents return. You can have an HVAC professional come in and actually tell you, are these barriers too much that it's actually compromising the airflow? They're usually pretty good at letting you know those types of things. But to be honest, in a closed space like this, what we've done is we've staggered the way people use it. So there's never more than a certain number of people in the room at the same time, and we've staggered their schedules that way. And we've always ensured masks are worn at the whole time. And we may use one barrier strategically where you can't have people face away from each other. And then you can also do other things. You can put a HEPA filter in there to actually get the air clean, to filter the air more often. So it's almost like you're having increased air exchanges in there as well. So all of those things will help. Ensure everybody has got their boosted doses of vaccination. Ensure everybody's washing their hands if they're all using the same terminals over and over again. So like you said, there's no straight answer, but there are ways to do other things that can be optimal to having multiple barriers, which also can be a trip hazard. You have to clean them. People shout over them. So it ends up making things, making you sort of create even more secretions or respiratory particles. Hopefully that answers your question, Tim.
Yep, that's great. Thank you very much.
So I will keep going, but feel free if there's other questions to toss them in there. So we can move on to cleaning and disinfecting, which is another bane of all of our existence. We never knew we had to do this, right? Until the pandemic. Even I wasn't that good at it, I'll admit. But the main thing about cleaning and disinfecting is you declutter everything in that area, which means you decrease the number of surfaces that could be contaminated. You open up the surfaces that actually need to be cleaned. And also you improve your airflow, like pertaining to the slides before. So one of the questions we get quite a bit still is about increased need of cleaning for SARS-CoV-2. So for SARS-CoV-2, there is really no need to increase or enhance anything above and beyond what is routine practices for what you would have always expected for a healthcare setting. And that's really important to know. We've all been there where we shut our offices down for 3 days after a positive person came in, did all of this deep cleaning, and you've heard about that happening all over in various sectors. There's really no reason for that. 4 top things that you need to do for cleaning and disinfecting in your office. 1, straightforward, make sure you have healthcare approved cleaners with a DIN number. That's Health Canada approved. Go to your regularly scheduled cleaning that you've always done for your office. You don't need anything more than that for the pandemic. Identify high-touch surface areas like telephones and keyboards. Make sure those are cleaned once daily and keep a log so people know that they are being cleaned, because that's the high yield areas you want to clean for not just COVID, but norovirus and other sorts of transmissible pathogens. And, when you clean between patients, you don't have to clean the entire room. You clean the surfaces or equipment that come into contact with their skin or their secretions prior to it being used on another patient. So just very, very much routine practice for cleaning, nothing extra needed for COVID. And hand hygiene, we have to have a hand hygiene slide in any IPAC talk. It's still important, guys. It's one of the most important and effective IPAC interventions that everybody can do. It's easily done. The key to this, though, is to have easy access to something to clean your hands with. If it's not there when your head says, oh, got to clean my hands, if it's not there, you're not going to do it. So make sure it's around everywhere you think intuitively somebody will want to clean their hands, but also where patient care is given around equipment that's used by multiple people, including things like the microwave, and then you will have easy access to hand hygiene. And one of the things that we can really do is teach patients how to properly wash their hands, encourage and watch them perform hand hygiene as well, which works very well. We do that at our screening at the front of our hospital. We all watch our patients wash their hands. And don't forget about hand care. One of the barriers to having good hand hygiene is people's skin falling apart. It tends to fall apart under rings. So it's important that if you wear a ring, ideally don't, but if you do, if the alcohol sanitizer gets stuck underneath, that you're actually rubbing all of that into your skin. Examine your hands, make sure that they're moisturized, and really encourage that practice in your office as well. Okay, so those are kind of your office logistics. More details about that you can find in our appendix. So we'll now move to direct care and kind of just move through a patient's journey through your office. So a patient comes into the front, they're screened, quote unquote, negative. Don't forget in the back of your head, this person could still be incubating something, just doesn't say yes to all my questions, okay? So patients should still continue to be universally masked. I think in healthcare, it's still important, and we all would agree that it's a vulnerable setting. It's a setting where we cannot lose capacity by having major exposures. And so, make sure, sorry about that, you still try to maintain physical distancing between households if feasible. We talked about where you can make some allowances for this. And next is another big question. What are we doing about eye protection? Do we still need to wear this stuff? Gives me a headache. I myself can't handle wearing that. So eye protection, we still have not a lot of evidence looking at transmission through your conjunctiva for COVID. And therefore, this practice of eye protection is something that we're still waiting to get a little bit more evidence on to see what the benefit is. So in the interim, the recommendations are that you still do it based on a risk assessment for these patients that could potentially be incubating virus and could still kind of have some of those droplets as they talk to you. And so, as per routine practice, if you're going in there to do a wound irrigation or some kind of procedure that could splash you, then of course you have to wear your eye protection. That's just universal for any type of risk assessment. Couple of things you can consider if you're going to wear eye protection for these routine patients that are coming in. Are you vaccinated? Are they vaccinated? If you're both vaccinated, good. Now your chance of transmission gets chucked down a little bit. Is community incidence and rates and all of those metrics we talked about, are they really high or are they really low? And that indicates what are the chances this person really has unrecognized COVID that could, splash into your eyes. If we're at an all-time low, we're seeing 0 patients in hospital like we did last summer, chances are low that they're going to be unrecognized. So again, risk of transmission down more. Is your patient unmasked? Is their mask hanging down at their chin and they can't put it up? Are they going to be removing their mask off and on? Are they a little kid that can't really keep it on consistently? Now that increases the risk a little bit. So that's kind of how the eye protection is now recommended, is to make that risk assessment. At the end of the day, if you're vaccinated, they're vaccinated, community transmission is low, but they're unmasked, we're still in a global pandemic. Most of us would probably still say, okay, maybe I'm going to put my protection on. But if I'm just going in to say, hey, how's it going really quickly, you probably don't need it, right? So those are the kinds of things you'd have to go through your mind when it comes to this type of risk assessment. And cleaning. So if you have a screen negative patient, do we still need to clean? Yes, unfortunately you do. Even for screen negative patients, the routine standard of care is you clean and disinfect anything that's really only come into touch with their intact skin, right? We still have skin organisms like MRSA and others that can transmit within a healthcare setting. So we still recommend that anything that touched their bare skin, which you try to minimize when they're in your office, just gets a cleaning and disinfection. Okay. So how about if your patient screens positive, you need to see them in your office. What you do is you book them at the end of the day, if possible. It's ideal, but if not possible, there's ways around getting around that risk mitigation as well. Make sure they have a medical mask that's well fitted. Make sure their support person gets a medical mask as well, because they may be from the same household. Keep them in the vehicle or bring them directly into the patient space if you're able to right away. And again, you have that identified space where this patient can be brought in where you have declutter, you have all the precautions, you have PPE, everything available. Try to batch all of your activities and not having 3 different people go in. Just you do the vitals, you do the history, the physical. If they need a test, you do the test. If they need a wound dressing, one person does the wound dressing. So you're minimizing the number of people who need to go into that room. And you make sure you put your PPE on, the right PPE, and just before you enter the room. Once you're done with your patient, you can even help by cleaning up after them and clean and disinfect sort of the area that's typically within 2 meters around the patient and any equipment that would have come into touch with their bare skin. If the patient kept their mask on the whole time and kind of sat in their chair, you don't need to clean the entire area around them because their secretions have been contained, their hands have been contained. So have a little bit of a risk assessment there too. So you don't need to spend all that time cleaning. And then make sure you remove your PPE right when you leave that room. So the last couple of minutes before we go to questions, I'll spend on PPE selection and a couple more things. So we have a very detailed resource that's listed here that goes through multiple scenarios of what types of PPE to wear. It's an interim set of recommendations until we gather more evidence on appropriate and effective control measures for Omicron and higher transmissibility variants. But in the interim, these are the PHO recommendations. But in your setting, there's probably 4 main things where you may encounter in terms of your daily activities. So one is you're the healthcare worker, you're providing direct care in that room, you're changing a dressing, you're taking vitals, whatever it is, you're in there, you're touching the patient. And if this patient is either suspect to have COVID or they're confirmed, they're test positive, then your PPE is going to be a fit tested, seal checked N95, eye protection, gown, and gloves. That's minimal PPE. If you're coming in after the patient is gone, you're just cleaning the room for the next patient to come in, then you can wear medical mask, eye protection, gown, and gloves. You'll still come into contact potentially with secretion, so it's important to wear the PPE. If you are a staff member who's doing that first entry point screening at the front where someone's coming in and you're asking them your screening questions, or you're even asking them, okay, what are you here for? Has anything changed with their health? Is this still your number? Everything, right? Whatever that first person does, that's ideally where you have that barrier. If you're unable to maintain over 2 meters, don't forget, you still need to keep your mask on behind that barrier. If you cannot maintain a 2-meter distance, you don't have a barrier, or you need to actually come into contact with that patient because you need to help that patient coming in as you try to screen with them, or there isn't enough space between you and them, then you wear a medical mask, eye protection, gown, and gloves while you screen them. And N95 is not necessary here because you have a very short interaction. You're not providing direct care. You're asking a couple of questions and then getting them on their way, maybe just holding their arm to help support them. You don't need to have the higher level of protection with an N95. For others, all staff, when you're doing administrative tasks, just keep your universal mask on. Unless you're alone in a room, you should really keep your mask on at all times. If you're eating or drinking, maintain your distancing in your break rooms. We have seen such a significant amount of transmission from staff to staff in break rooms, or when they've been, because you just let your guard down because you're with your colleague, you're eating and you're drinking, you're laughing. And so really, distance yourself while you're eating and drinking, put your masks back on, and then continue talking. But we have seen a lot of transmission there. These are just other PHO resources. These are lanyards you can print out just to remind yourself how to put on and the right sequence of putting on your PPE and taking off your PPE. So the last bit that I'll comment on is a question that was sent to us and asked to touch on is really one of the barriers that you're probably seeing in your setting is if you have a positive staff and they cannot come to work now for 5 days. And if you're the primary manager or the primary clinician in that office, 5 days worth of patient care is a lot because you're canceling a lot of patients. The current guidance, which would be applicable for the primary care setting or the office practice setting, is that if you are positive for COVID, no matter what, you have to self-isolate for 5 days if you're fully vaccinated, or 10 days if you're not fully vaccinated or if you're immunocompromised. And that's after symptom onset, and you have to be improving for 24 hours. And that's sort of the ministry guidance that would be applicable to your settings. Now, there is ministry guidance that give a little bit more leeway for healthcare workers to return to work early. That's applicable to what they call the highest risk settings, which is long-term care, hospitals, and congregate living settings. So where people and patients sort of are there for days on end or they live. You can extrapolate some of this guidance, and there's a link here that was just recently updated on April 11th. Some of this guidance can be extrapolated out into other healthcare settings like office practice, which also, has vulnerable populations, and they really can't handle a lot of staff being off in terms of access to healthcare. So there are some added things that may bring you back early. So if you have a subsequent negative PCR test, you can come back in before the 5 days are up. If you have 2 rapid antigen tests that are 24 hours apart and are both negative, you can come back earlier. You just have to also obviously be improving with no fever. And there are some other sort of risk stratified recommendations that's out of scope for this talk. But certainly if there's questions about it, they can be forwarded to us as well, or to the ministry. And this is just a slide that talks through the multiple layers of protection that is needed in a workplace or the general public. One layer of protection is never perfect. If you put multiple layers in, you have far better protection. So if you do need to compromise a little bit on the physical distancing, let's say that layer, because you really want to see your patients, just make sure these other layers are really well bolstered. And then that one layer is not going to have as much of a risk as it would if none of these other layers were as optimized. So we'll end off with some key messages. Routine practices are still required for all of our interactions, regardless of COVID-19. It's really important to establish an IPAC program based on a risk assessment. And, at this time in the province, a lot of our epidemiological indicators are going the wrong way, and a portion of our general population is yet to receive their recommended booster doses. So we really still need to adhere to a lot of these added IPAC measures at this time, like universal masking. And, there is a point in time that we're going to be able to adjust these measures as the waves kind of lull and go, and we move our way out of this pandemic. And just to finish off, this is the key resource that if there's one thing for you to read, this puts everything together in one document, and you can just go through it and assess your office, read more if you feel like it, read less if you feel like it. And that's it for me, Tim. So we can open up for questions, or you can call out a few that are in the chat. Thank you so much.
Great, thank you very much, Jaya. Yes, there are some questions. So one that I think is particularly important, well, they're all important, but reflecting on some of the other webinars that we've done throughout the pandemic for a variety of audiences, a common question is that extended use of PPE. So we're seeing that here as well. So if you can maybe comment on the frequency of changing, say, a mask throughout the day if you're not seeing a COVID positive patient, because I know that you've already gone over and in a lot of the guidance, if you're caring for or assessing a known COVID positive patient, then you have to change that to PPE, including the mask, upon exit of the room. But what about those cases where you've left those patients to the end of the day, or you haven't seen one of those patients? What's the frequency of changing that PPE?
That's a good question. So if you're going in and out of rooms that are screen negative patients, they have no signs of infectious disease, they're keeping their masks on, you can use that same mask for multiple patients. That's perfectly fine. Still advise you don't touch the outside of your mask. It's there to protect you, so the outside is dirty. If it starts getting hard to breathe through it, or if it's clearly wet and starting to get uncomfortable, then change it. If somebody coughs and sneezes in your face, even though they're screen negative, they just happen to have a cough because of dust or whatever, then if you feel like it's kind of got onto your mask, then certainly change it. But you can see multiple screen negative routine practice patients with that same mask you're wearing for universal masking without any issues. That we've seen that practice, and we're not seeing any increased risk from it. But as you said, if you've gone in and now you're using it as PPE because someone else is symptomatic, you have to assume it's contaminated, take it out as you leave that room.
Great, thank you. Also, we've seen a couple of questions, and I know that maybe the way we presented it on the slide versus what we've said verbally maybe confusing the issue just a little bit, and that's about cleaning. So the cleaning of horizontal surfaces. So I know what you have said in your comments is that it's mainly routine cleaning. But we've also indicated that those surfaces that the patient comes into contact with, those you need to clean right off. Can you go into a little bit more detail or clarification on maybe some of those horizontal surfaces around the patient? Like if there is a table or something very close to the patient, they haven't necessarily touched, but have been within 2 meters of where the patient has sat?
Yeah, so that's a good question. So maybe the word routine was a bit confusing as well, because routine practices includes those recommendations on what to clean after a patient has been in the room, and if that patient was in precautions or not makes a difference as well. So if there's a patient sitting in your room and they are, let's say, symptomatic, and if they're symptomatic, likely around 2 meters is where some of those larger droplets are going to land. So you can make a few decisions about what you're going to do. One is I would recommend you keep areas around where patients sit as clutter-free and free of things as possible. Where the patient is sitting, anything that they've touched with their sort of bare skin, that needs to be cleaned. If you put a blood pressure cuff on them or you've used a thermometer on them, any of that needs to be cleaned because it's directly touched them. The horizontal surfaces around them, most of us would just assume that they're contaminated because we don't really know what's happening in there when we're not in the room. If the patient's taking their mask off, they're sneezing, whatever it is, or if they've kept their mask on the whole time, it's still not 100% that it's blocking some of those droplets. So the general sort of assumption you make is the 2 meters around them, if they're symptomatic patients that are in your office, are likely contaminated. Horizontal surfaces just mean, like you said, if there's an exam table right there, if there's a desk corner right there, sort of clean those. The vertical surface are things like walls. That's not really necessary because that's not a high touch surface. It's the horizontal surfaces where you're putting other things on. So that's where you would clean it. There are some instances where I've had a patient who is symptomatic, they're well masked, they were in the chair for about 3 minutes, nothing around them really, and I've chosen not to clean around them, but that's because there's really nothing around in that 2 meter radius. You don't need to clean the floor, you don't need to clean the walls. So hopefully that gives you a sense. If you're not really sure, just assume within 2 meters of a patient sitting there with symptoms, those horizontal surfaces are likely contaminated with their respiratory particles.
And thanks a lot for that answer, because I think what you've illustrated, not just with answering the exact question, but that you're reinforcing that idea of the constant risk assessment. And I know, whether it's primary care, acute care, long-term care, in the support that we provide from Public Health Ontario, there's a desire to have more of a formula. So in this situation, I should do X, Y, or Z. And I think, Jaya, what you've just outlined in the answer to that question is that it's a lot of it depends. And I know that can be frustrating for some of our stakeholders, but you've really just illustrated that you can't necessarily have a hard and fast rule about never cleaning or only cleaning horizontal surfaces once a day, or cleaning them after every patient. It really does depend on what the interaction with is, what you've observed, etc. So thank you for that. I'm just conscious of the time. We do have time for a couple more, and just another quick clarification around PPE. So in the instance where you're seeing, let's say you've scheduled the patients who have screened positive under the COVID screen, you're seeing them in the office, They are at the end of the day, and you are moving between them. The changing of PPE between those patients, can you just comment on that? So it's kind of a cohorting question in essence.
So that's a very good question. And so the ideal scenario when we talk about best practices, you change all your PPE between each patient. Put new, fresh PPE, go in, do what you need to do. As you leave that patient room, take everything off. So that's your ideal best practice. But we live in the real world where we don't always have the luxury of time, which is not always an excuse, but really there's also a question of PPE and PPE supply and whether we have any shortages of PPE, particularly when we look at N95 respirators. There are times when your size may be in a shortage of supply as well. So if you cannot, for logistical reasons, or for supply reasons, do what's sort of that best practice standard of changing between patients, then there is a way to what we call extend the use of certain PPE. And we do have some guidance on that, and that outlines different scenarios. Rohit can put that guidance in the chat too, about when you can change different parts of your PPE. So if you've got 3 COVID positive or screen positive patients and you want to go between the 3 of them, either they're coming into the same room or you've got them lined up in 3 different rooms, whatever the case may be, definitely for sure your gloves must be discarded between patients. Gowns, ideally as well, because if you're coming in contact with the patient, the secretion's there. And if you're coming into contact with another patient after, the secretion is there as well. And you might say, well, they both have COVID. Why does it matter? We don't always only have COVID in our secretion. So we always have to think about other things that could be infectious as well. Maybe somebody is screen positive because they've been exposed. They don't have COVID yet. But say they really weren't highly exposed, but then now you're coming in with secretions from a known COVID patient to them. Now you may potentially expose them. So ideally, the gowns are also taken off between patients. You can, however, extend the use of your mask, whether you're using an N95 or a medical mask, and your eye protection. As long as you don't touch it and you finish your stuff, go to the next patient, you can keep that same mask and eye protection on. Wear your gown and gloves if you're going to be going in and doing anything with that patient, take those off, and then go to the next patient as well. So that's kind of how you can extend the use of some of your PPE, but some it's just too high risk for the types of things you're doing. And also for contaminating areas as you walk out of a room and back in a room is higher with the gowns and the gloves.
Okay, great. I am going to ask you one more question, and you're going to hate me for it because it's probably going to take a little bit longer than we have time for. So if you can just narrow things down. In the meantime, for our participants, we're going to put some polling questions on the up as well, and if you can answer those, it'll just help us plan for future webinars. So the final question that we have time for, or maybe not time for, is around high-risk exposures. So if you have, whether it's clinicians or others working in the primary care setting who maybe have children at home who are under the age where they can be vaccinated, and they have tested positive for COVID, or there's been a high-risk exposure, what are the implications for clinicians and their ability to come to work and see patients in the clinic setting?
That's a really good question. And it's a tough one because there is ministry guidance. And for primary care, you would fall within the ministry guidance for the general public because you're not considered part of that highest risk hospitals, long-term care, separate guidance that they have. And so for that, the recommendation, if you're fully vaccinated and boosted, you certainly can come back to work. That's in the guidance. I would still suggest that when you come back to work, understanding that the vaccine is not 100% protective, unless for Omicron, is that you try to kind of do what we call workplace precautions. So take your breaks alone whenever you're unmasked, keep your mask on the whole time, ensure you're doing diligent hand hygiene and things like that. If you are not vaccinated, then you have to self-isolate for the whole time that person at home is self-isolating as well. So the real answer is to get that boosted, get all your boosters if you're over the age of 18. if you're a staff in the office care. There are some contingencies for coming back to work early as a contact, but it actually doesn't apply to you. You get away with it by being part of the public guidance and not the way higher stringent, highest risk guidance.
Great. Thank you very much for that answer. Rohit has put the link to that guidance that you've been referring to in the chat. I just want to thank everyone for your participation today. This session has been recorded, will be available next week along with the slides. If there were any questions asked that we didn't get the chance to answer, we're going to receive those afterwards and we'll attempt to follow up directly. So again, thank you very much, everyone, and enjoy the rest of the day, and hopefully you'll get a rest this weekend. Thanks.
I'm going to leave the poll up for one more moment and then I'll end the session. Thank you, everyone.